Доброго вечора.
Hello, welcome. Hello.
Hello.
У нас поки що. Дуже дякую за те, що ви прийшли.
Thank you so much for joining
Добрий вечір.
and good evening.
Я думаю, що ми будемо починати
I
вчасно.
think that we'll start on time. I can see still a couple of people joining, but I believe that we should slowly start. My name is Anastasia Lukhina. I am an author of a book and also an editor on the empathy and humanity in healthcare, and we've developed this manual with my colleagues. I can see some of my co-authors here, and basically right now we invite you to the next broadcast of the Laboratory of Empathy in Medical Education, present on the diagnosis, to share the best practices on teaching communication in medical educational institutions and working on the courses development. I hope that you have already saw our manual. Maybe you even had a chance to touch it. Maybe here you will show the QR code. If you don't know it, you can download the complete manual. That was our experimental research to understand the next steps, what we should teach, how we should teach that, how to prioritize, and together with the team, we've experimented with this, and now in Ukraine, within a couple of universities, they have one or more courses or topics related to this, and we're very happy as a team about that. Hopefully you will download it and you'll also find something useful here. It's also important for me to mention that this series, this laboratory, is being recorded. We have a playlist. Tanya will share the link in the chat. So should you like to watch some previous broadcasts, because I was reviewing your questions in the registration form, and now I know that we actually answered a couple of those previously. So if you'd like to, you can go back, watch or rewatch everything on YouTube, because the link is available and the recording is available as well. Two things I'd like to mention. We're going to start an interactive presentation together with Claudia right now, and she prepared the lessons learned based from her own experience out of 25 or 30 years of developing and transforming curriculum in medical education. In case of any questions, please feel free to ask your questions in chat. And today we will try working in small groups. So that's as a warning. At some point, we will really ask you to switch on your cameras. Maybe you can do it right now. We'd like to see your faces. Maybe Claudia would like to see your faces as well, for her to see not just the black camera placeholders, but to see the actual people. So please participate in the breakout discussions a bit later. And today's focus is a strategic view at a curriculum and communications within the curriculum. I believe that today's discussion is very valuable, because I believe that in Ukraine, it's common for us when we have a look at the background of communication and teaching. So it's based on two myths. The first one is that it's enough to just introduce a couple of courses and that's it. And the second myth is, I believe that similarly to any other reform, we assume that one-time change will solve everything. And it's enough to do something, one thing, one time, and that will be it. And that will keep. But I believe that Claudia will share her experience, probably dispelling those myths that we face very frequently. So, briefly, I'd like to introduce our today's speaker, Claudia Kessling. We met her at a meeting that was a meeting of the working subgroup Teach International Association on Medical Communications, and I was really impressed with her, with how deep her knowledge is, her insight is, and her experience and the vision of a curriculum, the comprehensive system. She is very experienced. She has developed and has transformed curriculum in Berlin, Hamburg, Basel, Munich, European, and currently she is head of the department on education of personal and professional competencies in healthcare, Faculty of Health within Herdecke University.
With that, I pass the floor to you, and yes, welcome.
Thank you very much for this very nice introduction and a warm welcome to you all from Germany. And I'm very honored and it's really a pleasure to speak to you tonight. And I really admire your brave health professions in Ukraine. So I'm very happy to be here. And I would like to talk about curriculum development and how to establish, how to design courses and curricula about communication skills. And to give you a short impression where I come from, next, can we perhaps start the slides? I would like to show you where I live and work in Germany and at what kind of university I work. Do we see the slides already? Oh, yes, right, perfect. Thank you. The next slide, please. Okay, yeah. Here you see a map from Germany, and the photo is a photo of my university. I work at the University of Witten-Herdecke. It's quite new, actually. It was founded about 40 years ago. It's quite small. We have all in all about 3,600 students. And we have two faculties, Faculty of Health and Faculty of Business and Society, and I'm member of the Faculty of Health. In the Faculty of Health, we run the program for medicine, for dentistry, and for psychology. We have a small cohort that makes it much easier to establish and design courses. We have 86 students per semester, so about 170 students per year. I also teach communication skills for dental students, and here the cohort, the class is even smaller. We have 46 students per year. How does medical education look like in Germany? We have a 6-year program for our medical students. They start with the program directly after school. We have 12 or 13 years of school, gymnasium, and medical education is divided in 3 parts: 2 years preclinical phase, 4 years clinical phase, and a final year with clinical rotations mainly. The medical education in Witten-Herdecke is a so-called reformed program. Our students start with very early patient contact. In the first 2 years, they have problem-based learning, so it's always based on patient problems. We have a focus on family medicine or general medicine, and this is very special. We have an additional track to the traditional medical education about anthroposophic medicine, which is a very specific alternative form of medicine. Students can do it on top of their medical education. The next slide, please. I am a medical doctor by training with a master in public health. My habilitation, it's a bit equivalent to a PhD, is in the field of medical education, and my work experience is about curriculum development, delivery in Berlin, Hamburg, Basel, München, and Neuruppin, as Anastasia already told you. I'm a professor since now 6 years, and I'm responsible at my university for the clinical skills training for medical students and dental students. My teaching interest is mainly in clinical communication, but also in professional identity formation. So the pathway to become a doctor, to feel like a doctor, about resilience, teamwork, and patient-centered care. I am member of the International Association for Communication in Healthcare and member of the teaching committee and the assessment subgroup. Okay, next slide, please. I would like to talk about the following topics. I would like to give you a few information about the communication skills curriculum at my university for the medical students. And then I would like to talk about how to define the curriculum content and what is important about curriculum development. I would like to talk also about the clinical relevance of communication trainings, a bit about feedback and assessment, and then a bit about change management. If you have any questions or comment, please interrupt me, it's no problem. Anastasia will follow the chat, so she will inform me about any questions and comments in the chat, but please interrupt me, raise your hand, and then we can talk about your questions. Next slide, please. Now, how does the communication skills training look like at my university? And this is only one example. It's not standardized in Germany how we teach communication skills training. We have a consensus about the content, but the layout, the curriculum, the formats is very much dependent on the context and conditions at the single universities. We have a communication skills training from the 1st to the 10th semester, so 5 years. For our students, we have organized 77 hours of training. Of these, 30 hours are obligatory and the rest is voluntary. And we have 15 hours with simulated patients. We work mainly with small group activities. We don't have any lectures. We have seminars. Sometimes we start with a seminar in the plenary. It's about 20 students. And then we have small group teaching, either with role plays or with simulated patients in small groups, 6 to 8 students per group with a facilitator. We use e-learning before and after the courses. So before the students come to us, they have a e-learning module to prepare the course so we can focus on experiential, experience-based learning during the courses. We are also integrated with our content in 3 practical assessments in year 2, 3, and 4. The next slide, please. Now, this is very full. It's an overview about our curriculum and the topics we were able to implement in our curriculum. And to see the blue boxes with 1 to 10, these are the semesters. And then you see the boxes with the content of the single sessions we have. And in semester 1 to 4, we focus on basics, on the fundamentals of clinical communication. So we start with the students with structuring a consultation. What is important to structure the consultation for the patient? Then we have a session about building relationship and an introduction into patient-centered care. In the second semester, we focus on history taking and dealing with emotions, and we have a new session, a small session about saying farewell, how to support patients and their relatives when death and dying has become a topic. Then in the third semester, we start with the simulated patient contact, and the focus is on history taking, because this is one of the most important tasks students start with at my university from the second semester on. In the fourth semester, it's about sharing information, information provision. And we have several like clinical settings where the students can exercise with simulated patients how to share information. And then in the fifth semester, they start with their clinical phase of medical education. So it becomes much more clinical. We have sessions about handover, for example, or informed consent. It's about motivational interviewing, communication about errors, the difficult patient. This is purely reflection about challenges students face when they have contact or consultation with the patient. Then we have triadic interviews with parents and children, shared decision making, sexual history taking, breaking bad news, ward rounds, and again saying farewell because we think it's a very important topic, and how to communicate in emergency situations. So this is our curriculum about communication skills. And in addition, we have a few more sessions about medicine and society, about, for example, intercultural communication. We have a small track for resilience for the students and for teamwork.
Claudia, we have a first question.
Yes.
So after you have given an overview, the question is which elements of the curriculum were the most challenging or difficult to implement? The content, the methods, the teaching, or the assessment?
It's the most difficult to get space in the very busy time schedule of the curriculum. This is the most difficult part. It's not so difficult for us to develop the content or the formats, but it's very difficult to get the space for our teaching from our deanery. And the second point that is very difficult is to get in contact with the clinicians and to implement communication skills training in the clinical phase of medical education. You see this, that we have less sessions, for example, in the seventh semester, because here we were not able to convince clinicians to give us time to do clinical communication training. The same as with assessment, we were able to be integrated into assessment, but it was a long way and it took us more than 2 years. Any further questions? Yeah.
Thank you. We will proceed with more in the chat, I suppose.
Good, perfect. Okay, then the next slide, please. As I said, the national and local conditions vary immensely. It doesn't make sense just to take over an existing curriculum developed by others. So the first step for you is to think about your own condition, about your own medical education, how good you are, like implemented in the medical curriculum. And the first question to start with when you think about developing courses is, what would you like to teach students about clinical communications? What are the topics you find most important for your context? And I would like to ask you to think about it and then share your ideas in the chat. And Anastasia, I would like to ask you to summarize the ideas a bit. Yeah.
Sure, as soon as they come.
Good, perfect. Yeah.
So here are some ideas. The structure of consultations, empathy, work with emotions, bad news, conflict and boundaries. Toxic work environment and psychological safety. Inclusion. I want them to learn empathy and reflection towards patients and to themselves. Without it, the profession becomes dangerous, both for the patient and the doctor. Everything that was mentioned is important for us too. We spend a lot of time teaching to gather complaints and history. Other aspects of communication are still not taught regularly. So history taking takes all the space.
And I think this is an important topic, and I think you can teach a lot of like communication skills when you teach the students history taking. Absolutely. When you look into patient preferences, what patients find important when they meet a doctor, the second topic is information provision. So in Germany, it becomes more and more important to inform patients, to share decisions with them. And therefore, we decided that we would like to give as much space for this topic, information provision, than for history taking. And what we see with our students, for them, it's really difficult to address emotions. They don't do that, and they don't dare to do that. It's very, very difficult for us to convince the students that it really makes sense. So in all of our sessions, we talk about the topic dealing with emotions. And now when you see these topics, they are diverse, they are all important. The next question would be where to start. Shall I start with the basics? Shall I start with the topics that students find most important? So this would be the next step when you think about how to develop a curriculum. Next slide, please. And there is a pyramid, and this has been published a few years ago. And it's by Jonathan Silverman. He's very famous, and he's one of the most important teachers in the field of clinical communication. And he developed this kind of pyramid of maturity of a curriculum. And when you look at how curricula are developed, most people start with a single standalone course. And that's perfect. That's a wonderful start. And most times these courses are in the early years because it seems to be a bit more easier to establish them in early years than in the clinical years. And then the next step would be to have more courses and have more courses throughout all years. And then you need to think about to allow for cumulative learning. So to think about how do these courses build on each other? Do students have a progress when they go from one course to another? Or is it more additional that the courses are isolated? And I think it's very important to have an integrated approach, to talk to the people who teach communication skills in the first year and in the fifth year and ask them about what are your standards? What are your objectives? What is important to you? To come to an integrated, as it said, helically organized curriculum. And the next step would be to try to increase the courses, become more clinical, and then to integrate the learning into assessment. And Jonathan stated that this is a 20-year approach. And this is really a long time, and therefore you really need a good resilience and good strategies and some thoughts about change management. Sometimes you are faster, like Now I was in Witten a bit faster. It took us about 5 years to establish our curriculum, but now we start to rearrange things and we start to kind of fine-tune our courses. So you don't have to be like frustrated or sad that you have only been able to establish 1 or 2 or 3 courses in the last years. That's totally normal. And the challenge is to keep going.
Oh,
Next.
there is a next question, like what are the mistakes that universities make when they start reforming the curriculum, and like what could be prevented? What can we learn from them?
I think a good tip is baby steps. This is from Marcy Rosenbaum, and she's also very famous. And she also always says, start with baby steps and try to start with a successful project. And a success is very important to convince others. So start small, start to network early, start to train early, and then try to build on your successes. And sometimes it's really difficult to convince the faculty. So you need to spend some time on convincing the faculty and your colleagues, and especially the clinicians. And I think a mistake is to start too big without the resources, because then you have the chance to fail. And then there might be people who will say, oh, well, you failed, and they won't support you. Okay, next slide, please. Now, this spiral is a curriculum, and it might be the way a student goes through a whole curriculum of 5 years. And in orange, you see the early phase, a preclinical phase, a clinical phase, the last year rotation. And then you started to implement single courses into this spiral, like history taking in the preclinical years, a course of breaking bad news. This is BBN, so how to share bad news. Perhaps in the clinical phase, you have the assessments regular from the faculty. And this would be a first success to implement a few courses into this spiral. Next slide, please. And the idea now would be to implement more courses into this spiral and to see whether you would be able to implement at least 1 course per semester, so that students can remember, it's again about communication. Okay, last time we had history taking, dealing with emotions. This time it's about empathy, and I learned some techniques I can use now for the next course. However, the challenge is to have this cumulative learning, and therefore you need to think about the pink box in the back, in the upper back, in the quadrant in the slide, the outcomes, the objectives. And it would be good to have shared objectives for the whole course, for the whole program, for the whole curriculum. Next slide. And you don't have to develop these objectives again. There are lots of lists of objectives and outcomes published in the literature, especially for communication skills. And here's one recommendation for a very nice paper. It was done by the EACH, or Teaching Committee, and it's a European consensus of learning objectives for core communication curriculum in healthcare professions. And it's public in Patient Education Counseling. It's a very important journal for us as teachers for clinical communication, and I'm very happy to share this publication with you after the presentation. Next slide, please. And this is one table from this publication. It's a bit small and it's in English, but you will get an email with the Ukrainian translation. And there you can have a look into these long lists of objectives or content of a longitudinal communication curriculum. And here they divided the tasks in key tasks, so the fundamentals, and then the recommended skills needed and specific tasks. And they checked in the different publications and consensus statements where are shared goals, and these were the goals that were preferred by this group who worked on this European consensus.
And I just want to say that the link is in the chat.
Perfect. And now we would like to open breakout sessions. The next slide, please. And give you some time to discuss these tasks and to think about what of these topics are most important to you. And now, if you imagine you have 5 courses to be planned, which of the topics would you select for your students? And we would like you to discuss this with 4 or 5 participants in breakout sessions. And we will give you about 5 minutes, just a small brainstorming to get some ideas from the others. Okay, welcome back. I hope you had a good chat in the small group and exchanged a bit your ideas. We will not collect your ideas right now. We will come back to it at the end of the session and we'll have some time to talk about it. Okay, let's continue with the slide. Next slide, please. Okay, right. Now you have your courses and you have decided what to teach. And now here are some tips what is important to consider when you develop your courses. And one is a term from education. It's called constructive alignment. And this means that your objectives, your content, your course format, the learning, the teaching, and the assessment should be aligned. And this can be aligned by the objectives. So objectives need to be transparent for the students, for the teachers, for the planners, and for the clinicians. You also need clinically relevant content, of course, and carefully selected training methods. And as I said, we do most of our teaching in small groups, like 6 to 8 students, with a lot of role plays, trying out, and what is most important is feedback. That we have established a feedback culture that allows students to make mistakes and to learn from what they have experienced in the role play. So feedback, to my mind, feedback is even more important than assessment. Assessment would be the so-called summative assessment where you give grades or you decide about pass or fail, but feedback allows you much more for learning. And of course, you need to think about how to evaluate the course effects. And this can be done, for example, with a short survey about the satisfaction or the learning that students perceive by themselves. You can look at the structure, the conditions, resources you need, and this all gives you information about how well your course was designed and delivered. And what is very crucial is to have trained staff and staff that is knowledgeable about the basics of clinical communication, has the skills, and is able to reflect by themselves. You need to know a bit about basic learning theories, very basic, and it's important to share your standards, like use a shared consultation model or feedback rules. And it's very important to have also clinicians as trainers because they function as role models for the students. So, 2 very important aspects I would like to highlight. Next slide, please. Can you perfect? Is the clinical context or content and the clinicians. And this is really crucial when we teach and train communication skills. Next slide, please. Why is this so important? It's important because we know from the literature that empathy decreases in the course of medical education. And we know this from several studies. So students come to medical school and they value empathy very highly. Empathy is important when students enter medical school, but this attitude decreases. And when you look into the clinical phase, you see that students don't practice empathy as we have taught it to them in the classroom. So what are the reasons for this? And this needs further research. What students report is that the clinical phase of medical education brings a lot of stress for the students. And there is a hidden curriculum. It's not seen. There's a formal curriculum. This is what is planned. And there is an informal curriculum. This is that happens also next to the formal curriculum. And when you look at reasons why empathy declines from the formal and informal curriculum, you see that students sometimes have inappropriate learning environments in the clinical phase. So they don't get enough feedback. There is not enough training in communication skills on the ward from the clinicians. Their role is sometimes unclear, and there is not enough supervision. What students also report is that they have inappropriate role models, so the clinicians do not. And there is another very interesting publication from Marcy Rosenbaum. I mentioned her already. She researched the disconnection between the learning in the classroom and the learning of communication skills during clinical clerkships. And what the students reported in that study, it was a qualitative study, was that teacher role modeling do not reinforce what they had learned in the preclinical courses about communication skills. And that in patient presentations, for example, or in ward rounds, clinicians rarely discuss clinical communication skills. And feedback on patient presentations were mainly on content of the history taking, not so much on the communication styles of the students. And sometimes they got, I mentioned her already, she researched the disconnection between the learning in the classroom and the learning of communication skills during clinical clerkships. And what the students reported in that study, it was a qualitative study, was that teacher role modeling do not reinforce what they had learned in the preclinical courses about communication skills. And that in patient presentations, for example, or in ward rounds, clinicians rarely discuss clinical communication skills. And feedback on patient presentations were mainly on content of the history taking, not so much on the communication styles of the students. And sometimes they got like cues from the clinicians that students decided not to talk about communications that much and rather focus on medical context as they or content as they see it as a role model from the clinicians. Next slide, please. So for the success of a communication skills training, I think it's really important to have a good connection between the communication skills training and the clinical learning and the clinical rotations. And the best would be to have the communication skills training on the ward, not in the classroom at university, but in the hospital from clinicians or psychologists, whoever has contact to patients, nurses, physiotherapists, and so on. Next slide, please. Now I would like to talk a bit about what is important when it comes to workplace learning. So learning in the workplace. And this is called also situated learning. And this is sometimes rather informal than formal. Sometimes it's difficult to plan. And I think it has more to do with a good attitude than a good like course program. Sometimes you need to just take the situation where communication is important for a patient. So it's not, sometimes it's not conscious and sometimes it's really difficult to control. So learning is embedded in the situational context. And when you look at how learning functions in this workplace, students extract knowledge from context. They try to understand new situations they haven't seen. And it's important that they perceive which knowledge and skills are relevant. And if they perceive from the other clinicians or the team that communication is not relevant, they will not learn communication skills. So it needs to be shown to them that communication skills are relevant. And then they start to transform their skills, that they fit in the new situation, and that they will practice communication skills to master workplace-based related situations. So learning is very much social interaction. It's learning from others, very much. And it's an active, self-directed process. So we need to support students in self-reflection and feedback and how to organize their learning process. It's very much linked to emotions and the self. So we need to talk about with the students about their own emotions, insecurities, how they feel when they do a consultation, and to support them to become assertive and strong and a good member in the future healthcare professional education and practice. So reflection is a very important process when it comes to workplace-based assessment. And there's a quotation I like very much. It says, "Learning to do is part of learning to become and to belong." This is, I think, really important to share with the students. What does it mean to become a doctor and to belong to the medical profession? Next slide, please. So in our spiral, I built in red boxes. It's self-reflection. So we need to think about how can we support self-reflection with the students, and where can we be a good role model for self-reflection. When students see that we reflect, we as a teacher, we as a clinician, they feel encouraged to self-reflect and reflect on situation, communication, and patient care.
Claudia, I just want to add that the previous session we had with Urit from Israel, and it was focused purely on reflection and self-reflection in the classroom. So it will be possible to take a closer look on what does it mean and how students can be more supported in that.
Perfect. That's great. Thank you. Thanks a lot. So now I would like to come to the next breakout session with you, another 5 minutes to discuss, and perhaps we can show the next slide. I would like to share your ideas with others. Who are your teachers? Is it only yourself? Do you have colleagues? What's their clinical background? Do you have surgeons teaching communication? Do you have internists? Who are the role models? And how can you expand the number of teachers for communication skills at your institutions? What disciplines also teach clinical communication? And how can you get in contact and work together and share your standards? So who are the role model for your students? And I would like to invite you to discuss this in a small group, just to get some ideas, share ideas with others.
And before you go to small groups, I just put the copy of the slide in the chat so that you can take a look at the questions when you are in the middle of discussion. Claudia, it looks like we are back.
Good. That's great. Fine. Okay. And perhaps to give you just a small insight, how we work together with clinicians at my university. It's a very difficult process. As I said, it needs a lot of trust in the work of the others. We work together with the Department for General Medicine or Family Medicine. We do courses together. We also work together with the Department for Pediatrics. And we have a communication skills course on the ward from the pediatricians. And we work together with the Department for Emergency Medicine. When students learn all about emergency medicine, then we have the chance to talk about crew resource management and teamwork in high-risk situations, just to give you a small insight. And as it is so difficult to get in contact with clinicians for me, because I work at the faculty, we started to provide free trainings for clinicians at our hospitals. And this is a way to get in contact with teachers, to tell them how we work. And we give, for example, trainings in feedback, how to provide feedback, and also how to organize teaching in the clinical setting, very general. A good topic also is talking about mistakes. We have small training sessions for clinicians how to communicate about mistakes with patients, but also in a team. So these topics are quite attractive for clinicians. And now I would like to come to the topic of assessment very shortly, because this is a large topic and deserves another webinar. I don't know whether you have talked about assessment already. It's a bit complex, but I would like to say a bit about assessment and my experience, what is important. Next slide, please. If you would like to learn more about assessment of communication skills, there are a few publications about it, and I'm very happy to share those with you with like general principles and examples how to do it. And what we know when it comes to learning, we know that assessment drives learning. Students perceive content which is assessed as relevant. And content which is not assessed is not relevant for student, even if it's very relevant for clinical work. So my advice would be try to get a foot into the assessment system. And this would be the summative assessment, which is really relevant for pass-fail or for the grades. It's important when you look at practical skills like communication that you assess practical skills in a practical assessment. And there we have the so-called objective clinical, the OSCEs, objectives, I can't remember what it means, skills examination.
I think everybody knows what OSCEs are.
Perfect. That's great. Thank you. Thank you. Yes, thanks. And also the workplace-based assessment, that you observe a student in the workplace with a checklist or a grid, and then afterwards provide feedback. It's also possible to assess knowledge, but then it should not be factual knowledge, more knowledge about procedures, protocols, or about concepts. And then it's very helpful to start with a small patient story or vignette. But to my mind, it's really important to provide continuous feedback based on observed behavior from a credible source. Somebody students seem to view as important or relevant for them, like peers, multi-professional teams, clinicians, supervisors, or even patients. Next slide, please.
While Sergey is changing the slide, I want to say that we also had a separate session on evidence-based and assessment by Connor from Australia, and people can also watch it if they missed it.
Perfect. Thank you. Yes. Now, coming back to our spiral, I highlighted the assessment in red, the summative assessment, the like end of semester assessment, and also added in the blue boxes the word feedback. So think about how to provide feedback in your courses in about clinical communication. And now we come to the topic change management. Next slide, please. People or human beings don't like change. So it's very difficult to initiate a change. And most of our medical curricula, they are fixed. They run since 200 years sometimes. And clinicians or faculty, they don't like to change anything. So if you have a standing curriculum, it can be quite hard to find a place for your communication skills training. And there is a very old paper that collected successful strategies to enable change. What is helpful when you want to enable a change in your medical curriculum, like, for example, implement a communication skills curriculum? And it's a list, and the most important points are in the beginning. It's thorough consultation, ask others, experts to give advice, and then talking to people. So this is really important to convince people in the faculty, the stakeholders, important people, that a change is necessary and the change will improve the curriculum. Teamwork is very important. Don't do this alone. You need to be a team. It's too exhausting to do that alone. And try to establish a need for change, which is agreed. You need a successful project to demonstrate what you're going to do, and try to avoid of imposed change. Don't force people, or you can try, but then you will have resistance. Be aware of timescales. Try to present the type of change, like, for example, in the committees, and use the committees to convince others. Which are the committees at your faculty, at your institution, where education is planned or controlled? And these are the people you need to convince about the change. There are some.
Claudia, sorry to interrupt you, but I just want to say that we also had some of the questions around the issue of resistance in the forms. And on the one hand, you say, like, don't impose change because there will be resistance. And on the other hand, the resistance is already there, even when you don't impose, because people don't know, or they see it differently, or they have other experience. So you don't impose, you explain, and people resist. Like, how do you manage it best? I mean, both with students, but also with established professionals who are just used to do things. In a different way.
Yeah, thank you. Can you show the next slide, please? There's a very funny old paper, and they collected all the ways to avoid change. And this is what you might hear. We have already tried it. It didn't work. Department XYZ has already tried it, and it didn't work. We don't have the time, the money, the staff. We would want, but the students don't want. Or the students want, but the faculty don't want. That's American, isn't it? Or whatever country you would like to take. But our university doesn't work like that. So there are many, many ways to express resistance. And I think the first step is to anticipate it and to think about how to deal with it. And therefore you need a strong, a strong leader, and convincing people who are really good at finding ways to address these sayings. Let's try it again. This is evidence-based, for example. Have the studies. Show people. That's very helpful with the clinicians. When we do training, we always show clinicians the evidence that good communication does not take more time. So these are the arguments you need. Be prepared. try to convince. If you can't convince, think about how important is this person. Is it important to convince him? Or is it more important to convince others? And then you start with an successful project, and then you can show people who are against it, look, it worked out. It took this and that resources, money, people, whatever, and we were able to implement it. And this is about, you really need to talk about people, and this is time consuming. And this might take a year or two. Like for me, it took me 3 or 4 years to get in contact with one hospital we worked together with. And we tried again. And now we had the first training after quite a while. So be prepared. And sometimes you need others to go in and try to convince because you are frustrated and you can't do it anymore. And therefore you need to be a team. But I think the first step would be anticipate resistance. And it's normal. We all face this. You're not alone. And sometimes it's good to meet and to laugh about it and to see it with humor.
To laugh.
Okay, next slide. Perhaps we don't do a breakout session again, Anastasia. What would you say? No. Okay. So perhaps we can have some ideas from the plenary. So think about who supports you, who hinders you, where is the resistant, who needs to be convinced at your institution. Do you have the power to change the curriculum? And power is really important. Like me, I'm a professor, I have some power. And I use this to implement change. So you need people who have power. Who are these people? And it's really worthwhile to think about it and to have a strategy how to deal with it. So any ideas? What is important? Mm-hmm.
I just want to say that we also had a series of discussions with the people who already made their steps in implementing the change and took the leadership. And you talk about power, that you need people who have the power. And for me, the key learning from these discussions with Ukrainian medical education leaders is really about accepting your own power and being aware of what power you have.
Yeah.
And using your own power before you
Yes.
look for other people's power.
Yeah, be aware of your strength. Yes, absolutely. Yeah. And sometimes we know this from the literature with patients. Sometimes people can be convinced by evidence, but sometimes by narratives and not so much evidence. So you need a good story to tell. What's your story? And I think it's important to show that other people are doing it already successfully. And it doesn't need the resources, perhaps, that some think it might be necessary. And there it comes again, start small and then build from your successful projects. Yeah. And say yes. If you have a chance to give a training to others, to talk to somebody, always say yes. And even if you don't know how to do it, just say yes.
I think this is the message that comes up like very often. Like if you want to inspire others to do something and to learn yourself, agree to teach it.
Yeah.
And then what do you do with the imposter syndrome when you agree to teach something that you don't know?
Yes, you have to overcome it. I mean, we have a saying in German that the person with one eye sees more than the person without any eyes. And sometimes I feel me as well, that I'm not experienced enough. I'm not a clinician anymore. I don't know enough about pediatricians or pediatric work. Yes, but I know other things. And I think it's good to empower yourself and have a good team and also celebrate your successes.
How do you celebrate successes? I think we are very good and at like doing loads of work, but when it comes to celebration of successes, we are super moderate and we skip it because we have more work to do. So maybe how do you celebrate your successes in your team?
2 weeks ago, we had a meeting, team meeting. We are about 10 people. And then we ended the meeting with what I really appreciate when I working together with you. And we made a round, and everybody took another person and said very shortly, this is what I really appreciate about you. It's your creativity. It's your discipline. It's the way you organize things, for example. And this can be very short, like 10 minutes. Or exchange about what was the biggest success in the last 2 weeks. Not talk about all the challenges all the way. Talk about the successes also. Yeah. And if you have convinced one clinician, this is a success. It is. Yeah.
Because one clinician is more than no clinician.
Absolutely. And the biggest success, I'm sorry, I don't know whether there are any surgeons. The biggest success would be to convince a surgeon to do a communication skills training for the students. This would be the biggest success in Germany, at least.
Like
Yeah.
with that, you get bonus karma points, right?
Yes, absolutely. Yeah.
I think Ukrainian surgeons believe they don't need communication skills because they work with bodies and not with people, and they rely on somebody else to do that dirty work of communication.
Yeah, it's the same in Germany, but we have some surgeons who do communication skills trainings with their students, so it's a start. Yeah.
I guess
Okay.
because the surgeons
Yes.
can I say that surgeons just only don't want to recognize they need communication skills. We had one training with our faculty staff regarding communication. We have very big argues about, do we need to teach communication skills? Why is this important? And of course, surgeons were very much against. But at the end, they said, if you want to have your patient satisfied, you will communicate with him very properly, and they all know how to communicate and they can demonstrate that.
Yes, that's right. And this is an important point you made. I think it's also about finding arguments that are important for the people you want to convince, not for us, but for the people, like time, patient satisfaction. There might be a system at the hospital where you get credits from patient satisfaction, or a reduce patient complaints, for example. So these could be anticipate what could be the benefit for a community you want to convince. Yeah. Oh, yes. I would like to come to my take-home message. So the next slide, please. Right. So take-home message, some tips. Refer to a graduate outcome framework. And you don't have to invent it by yourself. Just take one that suits to your context. Select clinically relevant content. Allow for cumulative learning and increased complexity. Start with a simple task and then go to the more complex start. Don't do a Breaking Bad News course in the first semester. That's not a good idea. Transfer into clinical texts. Think about how can we implement workplace-based learning and provide room for guided reflection to belong and to become. Built-in assessment and feedback, and train your trainers, if possible, with a clinical background. And consider the enabling factors for change management. And the next slide, please. And if you want to learn more about the topic, there is a very nice paper published about 2 or 3 years ago, I can recommend to you, and I'm very happy to share this paper with you. So this would be my presentation, and now we have a few minutes left for your ideas and questions.
Not really.
Not really? Okay.
Well, maybe we have time for just like one question, and then I need to do the summary, and we need to close down. So if someone wants to ask a question, this is your last call.
Mhm.
Natalia, of course, Natalia Haliash. Who else could ask a question?
I just wanted to ask, just name very shortly what in what form you perform the summative assessment. Yes, you have mentioned that you have 3 steps for summative assessment. Is it OSCE or what?
Yes, it's OSCE. We are part of the OSCEs. Yeah. Yeah.
Thank you.
Yes. And we have like formative assessment in our e-learning modules, for example, and this would be then written assessment. Yeah.
Thank you so much. Maybe I try to summarize. It was a very rich presentation, and we in the facilitation training, we really emphasize how important it is to summarize so that people are clear and you yourself are clear with the takeaway learning. And in a way you did that with the takeaway messages, but still I want to recap a little bit like the richness of today's conversation. You started with the information about the curriculum is organized in your university, and you mentioned the things that I think get mentioned in every single session, and it's about working in small groups, facilitation, no lectures, and use of e-learning before and after, meaning also a lot of self-study. I also really appreciated your message that it doesn't make sense to take somebody else's curriculum. You really need to develop your own in the context where you are working with. And I think in the second part was more focused about like how do you do it and what is the most important and where to start. And you share the Jonathan Silverman's pyramid of maturity of curriculum communication curriculum. And I think the key message, there were 2 key messages. One was about first increase the number of courses and then integrate them among each other together. And then the baby steps, the importance that you don't do something grandiose, but actually start very small and gradually increase and better integrate. The third part, and I think focus was on constructive alignment, because as you build up new courses and you integrate them, you need to be very clear about the learning objectives, both with yourselves, but also with students and other stakeholders who are involved in the program. In the fourth part, I think you really emphasized the importance of informal curriculum, because before you were talking about formal curriculum, and the informal curriculum is something that students live and experience outside of what they are taught, but it's a learning environment, the role models, the mistreatment of vulnerability that is there. And I think you mentioned the word feedback in almost every part of it, how important feedback is. And I mean, feedback is definitely the word that is used a lot when we speak about medical communication, and we really pay a lot of attention on how to provide good feedback and what that means. For the fifth part was really the emphasis how important it is to learn in a workplace and incorporate communication training in the professional environment, and that how much of this training is embedded in the context, and how much of it is actually in the social interactions themselves, not just discussing them, and again how important self-reflection and feedback is in the workplace. In the sixth point, I think was really a lot about how to involve clinicians in training, and I think you offered some ideas in terms of what carrots you can offer to clinicians to get engaged, and those were also training in feedback and training in teaching, and training in communication. And I also remember that some of your colleagues from other universities said that oftentimes the clinicians are very hesitant to come and train, but then they leave the room saying that they probably learned the most out of this session and that you just need to give it a try. And then you talked about assessment. And again, here the feedback was the most important probably word if we were to summarize it. And last but not least, you talked about the change management and how you have to anticipate resistance and take it as a given. And then you really need to use a lot of communication and be very sort of power smart to find power within yourself, but also to find and convince people with power to help you. And again, I think that the key message of today is how to start small and also build on every small success and celebrate it, because it's actually appreciating your own successes can be a fuel for the whole journey. Yeah.
Thanks a lot. Thank you.
Thank you so much, Claudia. I just want to say that we will share the presentation and also the materials that Claudia promised via email. And I want to say that our next sessions will be in January. And there will be a session on integrating communication training into rehabilitation training and why it's necessary and in what way is it different from other areas of healthcare. And we will also talk about PBL, the problem-based learning, and what we can learn from the Ukrainian experience of Police Academy and how they restructured their very conservative and over-regulated training into a problem-based learning. So that is coming in January. And I want to wish you good holidays and calm holidays and lots of light in many ways. От бажаю вам гарно завершити рік і відпочити і
So have a
трошки
nice ending of the year, have some rest to relax a little bit and do some reloading over that period of time for you to accumulate energy enough for small and large victories that will come next year. So thank you for joining us. Thank you for your questions. Thank you for your active work today. Thank you.
Likewise, дякуємо щиро.
Дякую.
Thank you. Likewise. Thanks a lot.
Дякую.
Goodbye.